So welcome everybody to this next Center for Practice Excellence rounds. Speaker series. We've just recently changed our name, so I'm getting used to it. Welcome to everybody that is here in the room. We're right now at the Leslie Down Faculty of Pharmacy on the 4th floor, but we also know that we're joined by a number of people who are online. So thank you to those who are with us online. Just to remind people who are online that if you have questions or comments about what is being talked about today, please type those into your chat windows, and we'll be able to incorporate that into the conversation after each of our presenters speak. So don't be shy. If you're online, please try to participate in the conversation. Of course, to everybody here, we're going to have a presenter and a discussant, and they're both pretty informal people. So they'll present and have opportunity, we hope, to have time for questions and discussion really after each of the speakers, and then at the end. So that is our hope. So I'm going to introduce Zubin. We're very, very pleased to have Zubin back from sabbatical after being away last year. Probably feels like he's been back now for eons. But he is the director for the Center for Practice Excellence, and he's here as a professor and Conflict Chair in Pharmacy Management, and is going to talk about competencies today, which is very exciting. Turn it over to you.
Thank you very much. And let me first start by introducing our discussant for today, Dr. Robert Paul. This is an unusual situation insofar as about a year ago, Rob was not Dr. Robert Paul, he was Rob, my PhD student. But now he is graduated and all grown up, and he is the director for the Center for Ambulatory Care Education at Women's College Hospital, a very good use for his degree. And as I have no control over him any longer, I will now need to be polite and respectful, because he is going to be discussing and critiquing the presentation today. So the presentation today is titled, "If Competency is Our Answer, Have We Asked the Right Question?" And the idea for this presentation actually comes about from a whole series of pet peeves, I suppose, that I have accumulated over many years, almost like getting close to 30 years of working at the Faculty of Pharmacy. When I was a student, when Lisa was a student, when many of you out there were students, the word competency was never used in reference to people. We used to use the word competency to describe a bladder or a cervix or some other kind of a muscular organ, to say that it actually functioned properly. But somewhere, at some point, the word competency suddenly started to be applied to human beings. Not only did it get applied to human beings, it got applied in a way that suggested it was the highest possible praise that you could actually apply to someone. What we're going to be discussing today is in some ways an amalgam of a couple of things that I've been working on over the last few years. In 2016, I and some colleagues were commissioned by the Health and Care Professions Council in the United Kingdom to draft a report called "Preventing Small Problems from Becoming Big Problems in Health and Care." HCPC, or the Health and Care Professions Council, is the largest regulatory body in the world. In the UK, they don't have a lot of separate regulatory bodies for things like physiotherapists and occupational therapists. Many of the professions that we, in Ontario at least, know as having separate regulatory bodies are all put into this single body. HCPC was interested in this idea of small problems, preventing small problems from becoming big problems in health and care, because of a very well publicized and unfortunate situation that had happened about 5 years earlier in a place called Mid Staffordshire. Mid Staffordshire was a hospital in Middle England that unfortunately encountered terrible problems when lots of patients started to die. After a major investigation, one of the things that became apparent was that apparently no one was to blame. Everybody in that hospital was apparently competent to the minimal letter of the law as defined by regulators and their professions and their standards of practice, yet people died unnecessary deaths. This problem of Mid Staffordshire understandably caused a lot of wringing of hands and gnashing of teeth for regulators, and this report was part of this regulator's ideas for how to deal with it. Last year, when I was on sabbatical, I worked with some colleagues in the UK on a project that was funded by the National Health Service, and it was a study that aimed to understand complaints to regulators about paramedics in the UK and social workers in England. Why these two groups in particular, you may ask? We'll talk a little bit more about paramedics in particular shortly, but what was interesting about these two groups in particular is that they had an incredibly disproportionate number of complaints. Your risk of being complained about by the public if you're a paramedic or a social worker in the UK seemed completely out of proportion to other health professions. And the NHS was interested in trying to figure out what was going on and what we could learn about regulatory processes, competencies, and the safe and effective practice of professions from the experience of these two groups. The final paper I'd refer you to that has informed this presentation is a paper that was just published in Research in Social Administrative Pharmacy, and that was a paper called The Role of Disengagement in the Psychology of Competence Drift. This research was sponsored by the College of Pharmacists here in Ontario and really sought to understand what happens when people are labeled by their profession as being incompetent. Because if you're a pharmacist in Ontario, you know until very recently, we were one of the few places in the world where we actually had an objective, standardized process, the quality assurance process, that actually could label a practitioner as not meeting competence standards. That was a very unique thing, and it provided us with an opportunity to explore issues around the psychology of competence drift. So if you're interested in more reading, these are the things that the presentation is based on. But to begin with, what I'd like to do is ask you to think a little bit about your relationship with professionals. Because of course, even though all of us are professionals in this room and do wonderful things, at some point, every single one of us is going to actually need to trust or rely on the knowledge or skills or kindness of another professional. Whether that is a teacher working with your child, a nurse looking after your parents, or a lawyer helping you through some kind of a complex personal situation. Even though we are professionals, we will, in our personal lives, have to rely on other professionals. And when we think about competence in that perspective, what actually keeps you awake at night when you think about relying on other professionals? I'll take that as a rhetorical question for now, but it's actually a real question that I've asked many regulators in different parts of the world. And it's interesting when you actually ask regulators this question, because the word they almost never use is competence. Nobody wants a competent professional. Everybody wants an excellent professional. Everybody wants somebody who cares, who goes the extra mile, who doesn't end their job at 5 o'clock, but will stay later in case you need them to stay later. This disconnect between the rhetoric and the practice of regulation in most parts of the world and what the actual experience is of what we need from professionals really makes us recognize why we need to think a lot more about competence rather than simply accept that as educators, oh yeah, we've got competence standards, competency expectations, regulators routinely publish competency expectations. We need to think a little bit beyond that and perhaps more importantly recognize what happens when we spend so much time and energy focused on competence. What gets squeezed out, what gets overlooked, and what gets forgotten in all this talk of competence. In Ontario, at least, as best as we can tell, the first mentions of competence within an educational or regulatory environment occurred curiously close in time to the point when Della Croto first appeared in this province. No, it was actually curiously close in time, coincidental with the proclamation of the Regulated Health Professions Act in the early 1990s. And as far as anyone can tell, the reason the RHPA was first introduced and became such a pivotal piece of legislation, not just in Ontario, but a model for jurisdictions around the world, the whole reason behind, or the political reason behind the RPHA at least, was that in the late 1980s, there was a very high-profile case of sexual misconduct involving a physician. And at that time, there was a belief that the College of Physicians and Surgeons of Ontario circled the wagons, protected the physician, simply wrapped his gave a slight tap on the wrist, but the essential problem wasn't solved. If you fast forward about 4 or 5 years, this legislation was introduced, and what this legislation had at the core of it was a requirement that regulatory bodies develop mechanisms to ensure competence, maintenance of competence of practitioners. Sexual abuse was the problem. Was competence the answer? The transformational effect of the RPHA on jurisdictions around the world cannot be overestimated. Anywhere I travel, I was just in Australia last week, and everybody in the regulatory world knows about, talks about, is supportive of, and admires the RHPA as one of the most pivotal pieces of regulatory legislation in the world. It's had an outsized influence on regulation in many, many jurisdictions. But if that was the course by which competence entered our understanding of things, is that the answer to the problem? To think about that, I think we need to go back to some basics. And for those of you who are familiar with it, you will remember some of the pivotal work of Donald Schoen, who wrote The Reflective Practitioner, amongst other important works. For those of you that aren't familiar with it, get familiar with it. It's a really interesting and important thing to know about. According to Schoen, professionals have a very important and unique role in society. He begins with the proposition that life is filled with extraordinarily messy problems, things that defy very routine solutions, things you can look up in a book or follow an algorithm or get a computer to solve. If everything could be solved by an algorithm, you would have a society filled with technicians. Nothing wrong with that. But the reality is, when you have messy problems that dominate life, you need wisdom, judgment, compassion, and care. And these are vitally important things that professionals normally excel at. These messy problems reflect some of the issues that regulators face in trying to standardize professional work with competencies. Think about then how messiness reflects in day-to-day life. Think about this case. A child has been experiencing significant personal stress both at home and at school, and as a result is now falling behind. Worse, behavioral issues have now emerged that are being treated as discipline problems rather than as the psychosocial issues that they actually are. A teacher who knows that child takes the time to talk to him, learns more of the story, and in the course of the discussion, the child breaks down and cries and cries and cries. What should the teacher who's sitting beside a crying child do? A physiotherapist is trying to assess a patient's mobility and joint status and needs an X-ray ordered in order to do the job. He approaches a medical resident from the team and is informed that the patient in question, "Oh, that's not my patient. I can't do anything for you." And so 5 o'clock comes along, an order isn't signed, a patient waits. Is anybody incompetent in this scenario? A social worker is trying to help his patient who is homeless and without employment. The patient has just received chemotherapy and is suffering severe nausea at discharge. There's no drug plan coverage. The social worker takes several tablets of an anti-nauseant from the nursing station ward stock the patient has already received and gives it to the patient so he at least can get through the night at a shelter. Is this incompetence? What if it's Gravol? What if it's Granisetron? Does it matter what the actual drug is? These are the kinds of blurry professional judgment issues that, if you are a professional, you know dominate your day-to-day work. And yet they exist on these funny boundaries of competence that no one wants to take responsibility for, no one wants to define, and no one necessarily wants to deal with. Yet it's exactly these gray bubble zone issues that perhaps resulted in the tragedy of the Mid-Staffordshire Hospital. If we try to define competence, we don't get very far. Dictionaries define competence as the quality of being adequately or well qualified physically or intellectually. What we know in this room, and for those following along with the home version of this, is that competence has overwhelmingly come to dominate what we do. We spend so much time as educators measuring competence, ensuring competence, assessing competence, figuring out what does AFPC want us to do, what does CCAP want us to do, what does NAPRA want us to do. In all of this time and energy devoted to competence, what have we actually missed? If we look at what competence means to other people, it means very different things than what we might think it is. The literature tells us that when you look at patients or clients, competence can be understood as 3 factors: accessibility, affability, and acknowledgement. Patients want healthcare professionals who are there, who are nice, and who actually listen to them and acknowledge what's going on. Conspicuously absent from this list of what patients want is that they are smart, and that they are right all the time. Study after study demonstrates patients are extraordinarily understanding of honest mistakes. What they are not understanding of is rudeness or absence. And so from this perspective, what we know, and actually one of the first times this was ever studied was at OCP when Della and I, 25 years ago, in order to set up the IPG program, we did a study looking at complaints of IPGs versus Canadian graduates. And this is a pattern that we saw 25 years ago. It's been replicated in professions around the world since. That patients rarely complain about an honest mistake, that the most frequent cause of complaint in most professions can be characterized by impoliteness, and many fewer than 2% of all practitioners are ever complained about in a profession, and even fewer of them end up before a disciplinary or fitness to practice committee. Yet an enormous amount of time and money is dedicated to competency assessment and competency detection systems, both in regulation and in education. What do we know about competence from a practitioner's perspective? I always like to tell the story about what happened about 30 years ago when I got my letter from OCP saying that I had passed all regulatory requirements and I was now qualified to be an independent pharmacist. At that time, I was working in literally that particular day, I happened to be working in the outpatient pharmacy at Mount Sinai Hospital. And the first thing that I did as an independently fully qualified pharmacist was make a dispensing error. Literally, I should have known. That was my first clue. I dispensed the Thambutol, rifampin, and INH. That's how long ago this was. And everything got into the wrong bottles. And fortunately, the very sweet little old lady that I dispensed this to said, dear, the green one's supposed to be in that bottle, the blue one's supposed to be in that. I apologized, and I was like, oh, I'm very sorry. I fixed it, apologized, and nothing more ever happened from it. What most practitioners know is that competence is not a function of me, it's a function of my environment. If I'm dispensing 450 prescriptions by myself on a daily basis, how can you judge my competence? If I'm working with a bunch of bozos who don't know what they're doing, why am I responsible for them? If I work in an environment where I never get lunch, I never get to sit down, it's just go, 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 stress, 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 how is my competence being judged compared to others given this environment? For regulators, competence has been a moving target. The general mandate for regulators is to serve and protect. And in different places at different times, regulators have actually not necessarily got the balance as right as they would like to. Currently in the UK, and largely in part because of what happened in Mid-Staffordshire, there is a decided shift to something called right touch regulation. This notion that the way we used to do things, and we currently do things in places like Ontario, where we issue competency statements, where we issue standards of practice, where we have a whole litany of thou shalts to guide practice, may not work. And we might need to dial some of that down and figure out what is the real problem we're trying to solve. This perhaps is my favorite slide. What does competence mean as an educator? For those of us who have been teaching for a long time in a post-secondary setting, we know how much our jobs have changed. For those of you who've just started, you don't know how good it used to be in some ways. But educators, historically in post-secondary education, were more concerned with personal development and professional socialization. And now what do we spend so much of our time doing? Attending meetings to discuss CCAP requirements, filling out enormous numbers of forms in order to get a course change undertaken. The amount of educational bureaucracy that is connected to competencies and standards is overwhelming. And I don't know about you, but many times it sucks the life right out of me. And perhaps more importantly, it starts to suck the enthusiasm out of me. And that's a really important issue, as we'll see in a few minutes, in what it means to actually be competent. Finally, what do employers think competence is all about? It's about predictability, standardization, and efficiency, the production of interchangeable widgets who are able to fill any post that happens to emerge. If we go back to that typical day in healthcare, perhaps a typical day in the university, perhaps this is a quote that can help us to better understand some of the limitations of competency as a framing construct for what we do. This is a quote from ED in '97. We work in conditions where society provides little moral guidance to individuals. There's a breakdown of social bonds between the individual and the community. There's a mismatch between personal group standards and wider social standards, which produces moral deregulation and an absence of legitimate aspirations. ED is not some random executive director in 1997. He's actually Emil Durkheim in 1897, a sociologist who studied the life of factory workers and how boring it was to be a factory worker. What I would suggest is, because of the competency discussion, because of the cult of competency that has come to dominate so many aspects of health professions work, this quote from 1897 about factory workers perhaps could just as readily apply to healthcare professionals in 2019. Durkheim coined the term anomie to discuss what happens when people simply start to drift from their work, where work becomes so bureaucratized, so boring, and so disengaging, people stop caring. If there was a flaw at Mid Staffordshire, and again, the way that actually panned out, nobody appeared to be incompetent, yet a colossal system failure occurred. It was likely a failure driven by boredom, by disconnection, or by disengagement. This then brings us to almost the end of the presentation, and where some of my research has been going in the last little while, as evidenced by those 3 citations at the beginning, and that is in trying to really understand this whole issue of what causes people to become incompetent. The term that was coined in one of the papers that I wrote was this notion of competency drift. Historically, competency has been defined as a binary. You're either competent or you're not competent. But human beings don't work that way. You don't wake up one Tuesday and go, hey, I'm competent, and then suddenly on Wednesday, you're not competent. You drift from competency. It may take years or decades to drift from competency. Let me give you an example. When I was young, I used to love music. I used to listen to music a lot. I had records. It was fun. You'd call your friends over, you'd listen to records, and it was great. And then sometime in the mid-1980s, we moved to CDs. And I got CDs. Like, that's fine. You just slip it in and you listen. I still listen to music. And then sometime, I think in the late 80s or early 90s, something called an MP3 player suddenly appeared. And an MP3 player was different. You just didn't slide something into a compartment. You had to go somewhere and download something. And I never bothered to learn anything about MP3 players. But because I never learned anything about MP3 players, when the iTunes store came along, I didn't know how to do anything, and so on and so on. Having missed a small step in something, I started to drift from competency in terms of listening to music. And I rationalized it by saying, well, I'm too old to listen to music anymore. Oh, kids listen to music. I'll listen to the radio. That's absolutely, there's nothing good to listen to, et cetera, et cetera. It's so easy in the life of a person or a professional to miss a single step. And when you miss one step, you're embarrassed to ask when the second step comes along, but I missed that a few years ago, help me to catch up. Professional practice is not that dissimilar. And what competency drift perhaps suggests is that we slowly start to disconnect from our profession in a way that exerts a profound personal toll on us. I would suggest then that we have spent way too much time talking about competency in education, in regulation, and employment, and the real word we need to think about is engagement or connection. Rather than worrying about whether professionals are actually competent or not, we should be more worried about professionals who are disconnected from their professions. We know this in pharmacy because who is at the highest risk of not meeting quality assurance standards in the QA program? International graduates, people who've been out of school for 25 years or more, and people who work by themselves. Professional isolation is an incredibly powerful predictor of competency lapse. But what professional isolation really speaks to is disengagement or disconnection from that profession. This handy 2x2 provides one way of understanding this concept. And what it suggests is that when one's skills and with the skills that one has personally and the challenges one faces in one's work are not aligned, we run into problems. When you have high skills, but the challenge in your environment is low, you have boredom. When you have low skills, but the challenge in your environment is very high, you have anxiety. And neither of these states, emotional states, is really conducive to optimal human performance. In the middle, you have high skills and high challenges, and that's when we are at our best, when we are at flow, when we are able to be our best and fire on all pistons. If you ask most healthcare professionals the frequency with which they are actually in flow, I suspect it's lamentably low. The number of smart, nice, well-intentioned kids who get channeled into health professionals, because that's what nice, smart, well-intentioned kids, like most of the people in this room, do, have a lot of skills. And in profession after profession after profession, partly because of the bureaucratization of healthcare, they end up here. And it's a very short step from boredom to disengagement to incompetence. If you're interested in reading more, here's some additional readings for you. I will now turn it over to Rob to Discussant away. Thank you for your attention. Looking forward to the discussion.
Oh, well, thank you. It's actually kind of exciting to be here because it's almost a year ago that, as Zubin says, that I was his student, and so I don't want to suggest I've been waiting for a whole year to be here, and I don't have any resentment or anything like that I'm going to be taking out on him. I'm going to be try to sort of just draw upon that as a way to sort of like make this sort of the talk a little bit more, to sort of like to challenge you a little bit. And Zubin was sort of talking about this, various different things sort of caught me and as he was speaking, and one of which is he was thinking about the idea of the cult of competence and the idea of bringing it back to basics. Just to sort of, before I sort of lead into that, I just want to say, like, my own background working with Zubin was, I sort of did a doctorate looking at using sort of like Foucauldian methodologies, which I won't go into too much beyond the fact that to sort of say it was a bit of a time dabbling into sort of quite a lot of theory, a lot of ideas of thinking about language, and I also brought to that a real focus on history. And so Zubin's idea of working back to basics, I'm going to sort of take you back a little bit in time as well and think about as well the concept of competency a little bit like he did, but also in a slightly different way. And sort of, I can kind of conceptualize my role here, not just to sort of do a presentation, but in some ways a bit of a question answer to sort of like pose some questions to Zubin just for my own thinking and questioning and ideas about this. So in preparation for this, and I was told not to prepare much, so I didn't prepare that much, but I was just trying to get an idea of where the idea of competency came from. And Zubin sort of mentioned how that it had evolved from something that you talked about being a competent bladder, and then it migrated into sort of the idea of an individual. It became an individual characteristic. For my own sort of work thinking about this, I was seeing that sort of the idea of the cult of competency dates back a little bit to the era of the 1960s or 70s, and the concept of behavioral obligations, and the idea that a profession was becoming more accountable and had a responsibility to society. And in some of Zubin's work that he's speaking to and what he talked about today evidenced a lot of that. And I think in some of your other papers, your one you did with Dr. Whitehead and Dr. Hodges, looking outside of pharmacy, was considering how the emergence of different competency models exactly sort of evidence some of that and within the role of the practice of medicine. I also then was kind of thinking about sort of trying to look up some sort of ideas of what a competent pharmacist, being in the faculty of pharmacy here, how it might have evolved, or the ideas or identities that were linked with being pharmacy might have evolved over time. And so as I was doing that, trying to sort of find pictures and ideas, the concept of the trajectory of something of moving from being an alchemist to being sort of a clinician pharmacist to being a managerial or corporate pharmacist might have been some of the sort of the changes that have taken place over time. And with that, as you think about the concept of competency and what it took to be confident in each of those different roles has changed in each of those instances. And that also produces different sort of components and different sort of practices, different obligations. And as I was sort of wondering about that, and I was going to sort of ask to Zubin, as he's been sort of watching this trajectory and thinking about it a little bit, though I don't think you could quite go back to sort of the era of the alchemist. I was just wondering, sort of as you're thinking about competency as it's sort of changed, can you speak about sort of a little bit, or how would you comment on sort of the emergence or the practice of being clinician pharmacist, or to sort of out of being corporate pharmacist or managerial?
Well, that's a great question, and it's actually a question that maybe I would suggest we think about inviting another person to speak at this speaker series. That's another one of my PhD students, Jamie Keller. Jamie's PhD is actually looking very much at this issue and looking at the competing discourses of what it means to be a pharmacist, whether that's a business person, whether that's a healthcare provider, whether that is someone who follows orders, or somebody who has an independent practice as a healthcare professional. And a lot of her work is now starting to focus on this notion that at the core of the problem we have in pharmacy is actually a lack of an identity. We don't actually really know who we are and what we're supposed to do. And as we're seeing around the world, identity politics is a hugely powerful motivator for behavior. In the absence of actually a real identity, it's hard for us to know what this profession is supposed to be. And it's doubly hard for the people who teach this to know what are we supposed to actually be teaching. This issue of identity and professional identity in particular is really, really an important one. Many years ago, another graduate student of mine, Anisa Mohammed, this came close to a decade ago, she did a really interesting study examining what happens when pharmacists become patients or caregivers. The idea for this study actually came about because a few years beforehand, my father had a heart attack. And he was all the way up in South Lake Hospital in Newmarket. And being the dutiful son, every day I would schlep up to Newmarket and, go to the hospital. And being a hospital pharmacist originally, I was a colossal pain in the butt. I would ask questions. I would want to look at things. I would double check infusions and, partly just for busy work, but also I'm kind of legitimately interested. And because I work in a hospital, I know what can happen. Maybe wonder, do all pharmacists do this? And so her study examined community pharmacists who had become patients or caregivers, and to examine what was their response when they were in that dependent role rather than in their professional role. So she studied community pharmacists in basically the GTA, interviewed I think 15 or 18 of them, in-depth semi-structured interviews, and perhaps to her surprise, she discovered that all of them denied their professional identity when they became patients. Her hypothesis was that now, when it counts the most, where your health or the health of a loved one is at risk, you are going to pull out every stop imaginable. You're going to leverage everything you can in order to advocate for and get the best possible care. And what these community pharmacists at least told us was that they didn't trust their professionhood enough, and instead would rely on ingratiation, being nice and pleasant, and and they relied on their personhood rather than their professionhood in order to get the best possible care. Completely opposite the findings you see, for example, in medicine, where when doctors become patients, they're terrible patients because they are aggressively leveraging their professionhood. Her conclusion was what this represented was incomplete professional identity formation. That now, when it counts the most, if in your behavior you're not trusting that anybody cares that you're a pharmacist, people in the study would say things like, well, when you're a patient, it's really important that you trust your healthcare professionals. It's a very curious thing for a profession whose bread is buttered on the fact that we should be double checking healthcare professionals. People would say things like, right now it's more important for me to be a mom than to be a pharmacist, as though somehow they are mutually exclusive. You can only be one or the other. And somehow playing the mom role is going to actually give you a better outcome in terms of the quality of care that you're going to receive. All of that by way of saying Jamie's thesis is exploring the professional identity issue that you are raising. I think it's a really important one because, as anybody who teaches students, anybody who's graduated recently knows, we don't do a really good job of explaining clearly or believably what we do. And you get this terrible situation where we say things in school and may believe it ourselves, and then people go down to the local drugstore and say, that's not at all what goes on there. I've never seen a pharmacist in my life do anything that Karen teaches us in MTM labs. What are you people talking about? Oh, sorry.
No, I was kind of ripped off what you were saying.
I don't think so.
I think it'll pick it up.
You can
Okay.
ask them on the online, but I think down the microphone, it's pretty good. Because this identity thing and getting back to competence, I find so much because I have to think a lot about, or I try to think a lot about team-based care. And I always think when we're talking about teams, are we losing, how do we help pharmacists and other professionals maintain their own identity? And maybe it's related to competence, although now I'm less sure, but that engagement. And then if you're going to talk about that, Rob, but the idea that we're so focused on that, and I always say no, but we need to have professions hang together as well themselves, in this. And then pharmacists have to spend time with pharmacists sometimes. They can't just work with their teams. They're going to lose what that profession gives them and how they are as a professional. It can't just be one or the other.
My comment that I was going to be making about that was we're thinking about this in such all the time in the singular. As we move into professional teams, is there a concept of a collective competency that has to be considered as well, individually as an individual, as a profession, and with functioning within a team? How does that work?
One of the comments I was going to make, and now this is a good time to come up with it, is one of the struggles that we have with competency. Sometimes people say things like competency is a little bit like pornography. It's really hard to define. You know it when you see it, but it's kind of hard to specifically say when is something like pornography, when is it art, when is something competency, when is it not competency. Is a teacher who hugs a child incompetent in that situation? Is the social worker who steals a Gravol incompetent? Part of the problem is because we think in binaries, we think the opposite of competency is incompetency. What I would actually suggest is, what's the opposite of love?
Fear?
No, name it. What's the opposite of love?
Yeah, I think we can give differences.
Boredom.
Yeah.
I think that's the opposite of competency. And what the study about disengagement in, I think the disengaged pharmacists actually suggested to us, is the path to competency drift was boredom. It wasn't they hated their profession, they were bored by it. They were in that zone, and over time boredom is corrosive. It's corrosive to our will, our motivation to actually remain competent. And all of the stuff that the hoops regulators may get us to do to jump through to demonstrate competence, all of the hoops we get students to jump through to demonstrate competence has a cost. And that cost is boredom. And the consequence of that boredom over time is potentially competence drift.
So how do we fix that?
Well, I've got how long? So part of it is I actually think, and I think we are, I think certainly certain parts of the world, for instance in the UK, they are starting to emerge from what I would say is the cult of competence. This whole right touch philosophy that is now emerging in the UK, and I think will eventually come here, it's coming to Australia and other places, says that you cannot dissect professional performance through a whole series of things like standards of practice and just simply say, make it a matching exercise to say, this is what defines competence. One of the things that they're trying to do in some regulatory bodies in the UK is recognize that regulators are in a particularly powerful position in any profession because they are the only ones in a profession that every single practitioner touches. You may be a hospital pharmacist or a community pharmacist. You may belong to OPA. You may belong to CPHA. You may not belong to certain organizations, but every single person who's a pharmacist is connected to the regulator. So the regulator actually has a potential bully pulpit to steer things. And so one of the first and most important things to do is actually to assess this theory that widespread boredom, widespread anomie is actually a feature of professions. I don't think many people in this room would need to commission a multi-million-dollar study to say that if we talk to most pharmacists, especially community pharmacists, but most pharmacists, most of them are here. Most of them start out hoping they're going to be here when they graduate, and very quickly, this tends to be their life. What happens when you spend 5, 10, 20 years as this is your professional life? So one of the things that we actually need to do is first pay attention to this and problematize this and accept that this is actually an issue. And regulators have a unique opportunity perhaps to work with employers, for example, to say these are the consequences when you have a profession-wide, a whole profession filled with people who are bored. There are real consequences to this that we are actually seeing, not just in our profession. The same problem happens in family medicine. The same problem happens in nursing and physical therapy. There's a really interesting thing about the paramedics I'll talk about in a few minutes as well, which is quite fascinating. And then we actually need to spend time and energy we are currently spending on assessing competence, I would suggest, and redeploy that time and energy to focus on re-energizing the profession, doing something to help the profession, doing something to actually help shift things up the curve a bit. What those specifics are, I don't know. But there's lots of it, not sort of just the traditional, hey, let's have more continuing education. It actually means trying to recognize that the reason people became professionals in the first place isn't what's feeding them today. It goes back to Donald Schoen, that we need people to be able to exercise wisdom, judgment, compassion, and care in their work in a way that they don't really do so right now. I know that sounds kind of overly idealistic, but I don't think it actually has to be. At the very least, if we can remove bureaucratic constraint, that's going to be a first big step. Rather than worry about pharmacists, though, maybe we should worry about people in this room. I made the comment that like somebody who's been teaching here for like getting on to 30 years, I'm finding it withering. And I'm chair of the curriculum. I was formerly chair of the curriculum committee, so I'm part of the problem here. But this whole notion of how on earth do we actually deal with all of you as teachers, for example. You're hired in the first place because you're really good at what you do. And then we bind you. We compel you to spend a lot of time filling out forms. We spend a lot of time doing very mundane tasks, doing things that don't allow you to fire on all pistons. And what happens? And when educators start to get into this kind of a zone, what are the corrosive effects from there? I actually do think this is a much bigger problem across so many different levels of professions, but it's a problem that's an iceberg that until it becomes a tragedy like Mid-Staffordshire, it still goes on.
So I could challenge you on a couple of things.
One, that's why you're here.
You're speaking about competencies in a singular. And in the language of competency, the discourse of competency, there's much of the idea of multiple competencies that be a requirement. You've evidenced yourself several in there, one of which is social advocate, communicator, and so how does that sort of play into this situation? And I would also throw out to you, at least in medicine, there's a movement to competency-based education, and that's challenging this concept of boredom, but it's really sort of challenging the relationship between the regulator, the practitioner, the government, the claimant resources, and I would suspect if one sort of deployed that sort of learning into the practice of pharmacy, that would bring in sort of a more commercial environment. And how is that changing? So I don't know in medicine that it's actually necessarily, there's definitely no agreement that sort of getting rid of the boredom of what competency was, how education is being provided.
To me, what it comes down to is a certain bureaucratization that has crept into so much of what we do. Whether you are an employee pharmacist, whether you are an educator, whether you are working in regulation, things have bureaucratized and sclerosed in a way that individual professional judgment, wisdom, compassion, and care are not valued sufficiently. When they're not valued sufficiently, people stop trying. When they stop trying, they get bored, and when they get bored, they drift from competency. The issue is a certain kind of bureaucratization, I think, that has taken what's actually a fairly reasonable idea. Like, how can you argue against competency? Of course, you can't be excellent unless you're competent. But competency has now squeezed out discussion of excellence or creativity or innovation or care or compassion. And we're satisfied that competency alone is all we need. Competency may be necessary, but it's not sufficient. And we're treating it as though this is all we need to assess and everything else is great. And I actually think with professional work, it's exactly the opposite. It's necessary but insufficient.
Asking a crazy question. Just in this last year, or the last 2 years, there was the addiction, the injection sites were happening down at Moss Park. And I knew a lot of people from the Wilson Center and from nursing that were down there very much involved in that, and it was a drug-related issue. And did this get picked up at all? And you gave an example of the idea of the pharmacist being taking drugs from the clinic to help someone. Did that sort of get picked up as a role or as a responsibility, or did pharmacy get involved in that?
Let me turn it over to our local expert, Dr. Beth Sproul.
Yeah, there was less of a role just because of the skills that were needed for that. Like, I guess, supplying. So certainly pharmacists went and visited the site and offered help, but it was very much a more of a so there were nurses there, but it was like an observational thing. You're just watching them and people overdosed and responded. So there was certainly could have been. I would say that there was more nursing and medicine than pharmacy taking over.
Why do you think that was?
I think it could be related to role identity, less kind of hands-on in an emergency situation like that. But pharmacy really has, or in pockets, taken on though the responsibility of naloxone training and the take-home naloxone and getting it out there. And certainly there are, I think we can, it keeps increasing how many pharmacies are doing it, but certainly in pockets at CAMH, we've had pharmacists who train over 1,000 people, patients and staff, etc. But at the same time, there are some specific pharmacies in Canada where they have taken on a role as a safe injection site or prescribed heroin or hydromorphone for self-injection witnessed, and they still usually have a nurse there to be the one that's looking at this, monitoring the person.
Do you think that's countered a little bit, the sort of the idea of the concept that Zubin has challenging, raising up the idea of this emergence of boredom? Has that given within the practice another way to sort of add different dimensions so that it's pushing up towards flow?
I think pharmacists do need to see themselves more proactive in their role in the crisis, for sure, whether it's dispensing opioids in particular and how much is dispensed to appropriate use, etc. But I think pharmacy still, again, from an identity point of view, I think pharmacists still see themselves as kind of a more hands-off profession, right? And not sort of there jumping in, actually touching the patient and doing things, right? And so,
to me, actually, that's a really good additional example of how the problem with competency, because all of those pharmacists who for a decade or more have been dispensing, just dishing out morphine, for example, fentanyl, or they were competent. They filled prescriptions effectively and accurately. If doses were completely out of whack, they probably called somebody about it or verified it. But all of those incredibly competent people created a crisis because they weren't thinking, because they weren't caring enough to say, wait a minute, because caring about your job isn't actually a competence the way that we've defined it, and that's a problem.
but also it kind of goes
caring about people, it's not caring about your job. Is it caring about your job, or is it caring about people as part of your job?
That, because
Okay.
I say they're the same thing, and caring about your job should be caring about your people, but what we've cared about is, have I actually met the letter of the law?
although, like, one of the key drivers of the opioid crisis, though, was the standard of practice at that time was, as a lot of us were taught, that people are being treated to get as much opioid as they need. It's subjective. They need more, they need more, and it was good intentions without recognizing or having the potencies that didn't really help. And the concern is we're going down that path again.
Is that sort of a Nuremberg defense of, I was just following the rules? In a somewhat unthinking, but that was the rule, so I follow it. My job is to follow the rule, as opposed to actually exercise wisdom, knowledge, judgment, compassion, care.
Isn't that more apathy though than like the high
Boredom,
skills, right? Like
Yeah.
that's like I'm just following.
Yeah,
Like
yeah.
to me that's apathy.
And maybe that's actually where we are. where it's a low skill, low challenge environment, and
Well, it's also, I think.
sorry.
Oh, go ahead.
Yeah, no, I've just been thinking a lot about some like the adaptive expertise literature and what an adaptive expert is, and somewhat of what I'm thinking about is that often people are in an environment where there is a lot of, it could actually be challenging if they've engaged it, but some of the work out of Japan talks a lot about you need, not only do you need an environment where there's a lot of variation, but you also need to be in an environment where you are going to be punished for doing something different, which speaks to a lot of the other things we're talking about.
Yeah.
If that makes sense. So
Yeah.
just,
And that's where I
Or
actually think,
you're empowered to do it, right? Like if your boss is saying you need to do 40 meds checks every day, I don't care how good they are, but
Yep.
like that's your quota, then like that could be like challenging but you're just like not empowered to make that a meaningful activity.
right, it becomes
Right.
just a bureaucratic hoop that you're
Right.
jumping through. I'll refer to Della for her time at OCP, but the number of times pharmacists would actually ask you, what should I do? Like, what's the rule? Like this sort of regulatory paralysis that, well, is OCP going to do this? Is
Are
OCP
you
going to come?
be
Yeah.
mindful?
Am I going
Yeah.
to be punished? And it's goes back to Naomi's point that, it's fear of punishment that, and in many ways, that's what the culture or the cult of competence really is. It becomes a bludgeon to use against people, or that's the perception, rather than a tool to empower people.
So that's interesting, because I would have said if you were confident, you would be asking OCP whether or not you were going to be, whether it was okay to do this. That you would be using wisdom, judgment, thinking in the best interest of the patient,
Yep.
documenting what you did, sort of thing. So that's interesting.
But that's
interesting.
yeah.
Like, what is competence for
Yeah.
that?
Because competence has evolved into a lowest common denominator, what's the absolute minimum I need to do so I don't get into trouble? And then why should I bother trying to do anything more than that? Because, why risk it?
So I have a question. So, we know the bottom feeders, we've studied them.
Mhm.
So why are there some, you know what I mean?
I know what you mean.
So
The
why,
disengaged.
so why are there some people are like, just like at the top of the profession, always looking for something new,
Yep.
like, throughout their careers, even when we did quality assurance, people think, oh, as you get older, you're less confident. That's not true. There's some highly, highly effective older pharmacists who have. So have we studied,
Yep.
like how, who are those people and what are those?
So this is actually something this is something we're doing actually right now. We're looking at, so what we actually did for this study is we contacted award-winning pharmacists, because that was the only proxy we had for who was excellent. So people who won like Pharmacist of the Year awards, and tried to figure out, so what are you doing that makes you an award winner, and by extension, therefore, an excellent pharmacist? The assumption for this study was actually that those people would be in flow. Somehow they had found the magic to be in that sort of flow zone. And interesting, that's not what we found. That they spend lots of their day in boredom or in apathy. And what they seem to actually have that perhaps others of us don't have is a certain kind of resilience. So what they actually do is it's not that they've actually necessarily changed their working world. They just have a certain kind of psychological adaptability to it that allows them to find some happiness or comfort in that, where many other people just can't. They don't have that resilience or grit or whatever word you want to use. But it's not as though those award-winning pharmacists necessarily have done something that they perceive to be transformational and put them in the flow zone. So this is actually something we're going to be hopefully publishing in Research and Social Industry Pharmacy this year.
So who's in flow?
Sorry?
Do you know? Like, can you identify? Like,
Flow exists.
yeah. What does flow look like for pharmacists?
Okay, so if you talk to psychologists, the flow experience they talk about it in terms of peak performance. So the example that's frequently given is people are in flow when they are, and it depends on you as a person, If you are driving a fast sports car on a windy road with the top down and the wind blowing through your hair, if you are playing the piano, when you're doing something you love, the characteristics of flow is the sense that time has gone by really, really quickly. It doesn't feel like work. You have this profound connection to what it is that you're doing. And it's a very subjective experience, but this is meant to depict what Marlene Scarnavalia used to call peak performance. This idea that you are just firing on all pistons and you are as creative and productive as you could possibly be as a person. One of the objectives of this study looking at these award-winning pharmacists was try to actually exactly answer that question. What does flow look like? And we couldn't get an answer because that's not the way that they're perceiving their world. It's not that they're in flow, they're simply demonstrating certain resilience strategies that allow them to adapt to their environment.
Which doesn't mean they're not anxious or bored.
No, but they actually just have superior coping strategies for boredom, apathy, and anxiety, rather than actually being in flow, which is not what we thought. We actually thought if you're an award-winning pharmacist, you are going to be in flow. That's not the way it seems to be turning out.
Yeah, this is reminding me, and maybe this is a good data source to go back to, but the transcripts that we had when we first had pharmacists embedded in family teams. So you may or probably don't remember that a lot, but the first 4 months people felt like they were on a roller coaster. There was a lot of anxiety, and they were never bored. They had a lot of issues on trying to figure out how to be in there and involved. But by 9 months, everyone reported, maybe not exactly what you said about flow, but a lot of the characteristics of they're in the zone, right? In the zone. But they didn't, it wasn't resilience, like not the way you described it, but the other sample that you said. And so I wonder if there's something to learn there about this, like these things that you're talking about.
Another good person to invite to the speaker series is another PhD student, Jennifer Lake, because Jennifer's thesis is actually looking exactly at family health team pharmacists and to see sort of how their integration is progressing. And it's interesting, all these years later,
are they still?
Yeah, sort of what's actually happening.
Now, obviously, we know that there's definitely different types. There's like
typologies, yeah.
That's right. So that'll be interesting, I'm sure. But a lot of it, anyways, that maybe we should look at these transcripts as well, because the conversation is had a lot of, as I realized, it has some of this, these aspects to it.
The interesting sort of corollary of all this is, what should we be doing as educators? Should we be spending our time and energy trying to invent flow, or simply teach resilience? Because those are two really, really different things.
Or how do you teach? Like, can you
or
teach
move the bars differently, like ratchet down the anxiety or up the anxiety. Like it's not just anxiety yes or anxiety no, but there's levels. And levels of boredom. Like move things. Don't go to the hardest keys first. Go and ratchet it up over time, and then help people get to flow.
Or is it the people that are just sort of identifying that are comfortable with their understanding what the discursive position or construction of a pharmacist is at that moment in time, and it's concordant with their ability to perform that. Right. So the role of the school then becomes to either educate and train people to sort of perform that sort of role, as opposed to what sort of like the other different ideas of competency are, or conversely to act on sort of trying to shift the concept of what society's idea and expectation for the role of pharmacist is.
And that goes back to the identity issue.
Yeah.
Figure that out.
Good one.
So have we looked at, like, is your ability to make more clinical decisions, have more authority, does that affect flow? Like, I'm just thinking about all the pharmacists in Alberta with prescribing authority. And the reason I say that, and I didn't think of it until you talked, was that my cousin is a community pharmacist in Alberta, and saying, like, I'm in my 50s, so I should be thinking about retirement, and I've never enjoyed the profession so much as I do now. But he has taken it. He wasn't one of the instigators or whatever. Like, he was one of the people who looked and said, "Oh, okay."
He wasn't an early adopter.
Yeah.
Yeah.
But he's just saying like his practice is just so rewarding, fulfilling. So
That's a great question, because these studies I'm talking about, they tend to be in Ontario. As we know, Ontario is a bit of a laggard when it comes to this. Do you shift the flow curve through things like, major standard of practice change? That very well could be. And then that starts to connect back to professional identity, because if you actually then have a clear identity about, well, this is what I'm supposed to do, you live up to that. Whereas now we're in this sort of, what is it that we actually... So Vanita's hand up.
My brain is just kind of muddled into I don't know how many directions right now, so thanks. I've just got a few shooting comments out there. I don't even know, maybe it's our definition of competence. Maybe we shouldn't be thinking of competence as the lowest common denominator. Maybe we should be shooting for a different bar. Maybe our definition of competence as educator should be not the LCE denominator, but maybe it's the highest variable. Maybe it's that combination, right, of wisdom, caring, judgment. And I don't know if we need to be in better cahoots or conversations with the employers of our graduates, right? They're Jamie's thesis, right, on identity. We've got pharmacists who are being walked off the job because they work in a messy fashion on a counter, but they don't make mistakes. They're great pharmacists, well, so I think great, but they're losing their jobs because they don't work in a way that a corporation wants them to work. We're not teaching to that at all, right? So we need to sort out who we are and maybe have that discussion with the people who are going to employ the pharmacists after and make some kind of agreement. It'll never happen.
But it's nice to think about.
Maybe we need a chair, and maybe you need to be the chair of the committee on flow and resiliency, right? With guiding principles on accessibility, affability, and acknowledgement.
Because that's what we need, another committee and more bureaucracy.
We need more of that, absolutely. But all those concepts, like when you first put that up there, I thought that's fantastic. And now I'm thinking that's just like a big blurry blob. There's no lines there in my mind anymore. They're all overlapping because in any one given day in a pharmacy, I'm at my peak while I'm bored silly, right? And then sometimes I'm at my peak and I'm anxious. And sometimes I'm none of the above, I'm just hungry. So you just messed up my
Good, that's the purpose of the speaker series.
I'd like to make a short comment about
As the only person who actually works for a living in the
the different mindset between playing a defensive role, which is I think of what we've been taught to identify and prevent mistakes, and then changing that to an offensive role, which is what I think could be the future and where you can make. So the defensive is community pharmacy, where you can really only catch and prevent mistakes. It's really hard to make a positive change. Whereas if we set our own stage, a new environment where we can make a positive change and start playing offense and have a different mindset. Because what happens is you turn into like a cop who's doing stops every day. Why are you lying to me? What drug is wrong? What are you not telling me? And that just wears on you. That erodes your thinking. And then you eventually one day, you can't think of anything else. But I think shifting and taking our education from playing a defensive role, even regulatory defensive role, shifting that to improving the health and the lives of the patient, Ontario, and finally the profession.
For those who aren't here, the last person who commented very famously when he was in pharmacy school did a Pharmacy Follies skit titled Pharmacy Linebacker, and it's nice to see that you're still talking about offensive and defensive role. I think that actually, I think that goes back to Della's comment, that maybe one of the ways towards this flow channel really is a liberated scope of practice, similar to what happens in places like Alberta.
So knowing the time, we can all talk for a lot longer, I think, on this really interesting topic. And thanks to both of you for giving us this time and space and wisdom to be able to have this conversation, continue this conversation, I think. It'll weave through, I think, lots of other discussions that we have over time. So very appreciated. Thanks to those of you who joined us virtually. Very appreciated. Thanks to Angus and Conchita for helping set this all up. and we'll see you at the next Center for Practice Excellence Speaker Series session.